Okay, guys, let's just start from our notes. So, in notes, we will be whatever I have told you, that's written in words. That's it. So, first thing you need to know from abdomen is lumbar puncture. The level L45 interspace, nothing to explain. Then, why L45? You have to know the vertebral levels of these. Do you need to know a lot of vertebral levels? No. You just need to know the ones I'm telling you. Only those you will have questions from. So spinal cord ends at L1 in case of adult. But it can vary from T12 to L2. That's not important. And in child, L2 to L3, remember L3. Okay, remember L3. Dural sac ends at S2 in case of child, in both children and adults. In case of child, it can go up to S3. Okay, so that's why we need to avoid spinal cord injury. That's why we do it in between L4 and L5, this level. Okay, this level. Then, then we have layers of lumbar puncture. So this is a classic question they always ask. They always ask about the layer. This is the skin. Then we have superficial fascia. Then we have supraspinous ligament. Okay. Then we have supraspinous ligament. Then these are the spine. These are the spine. These are the spine. We get interspinous ligament. Okay. Interspinous ligament. Then the ligament we have, that's the toughest layer. And you may find a resistance, and you push the needle and you hear a sound, a subtle sound. And that means that you have crossed ligamentum flavum. Because this is tough, that's why you get a resistance, it's tough. And then when the resistance goes, that means you are inside the spinal cord. Like you are inside the vertebral canal. You are inside the vertebral canal. You are inside the vertebral canal. So now inside the vertebral canal, we have spinal cord. But at this level, we don't have spinal cord. So that's why we do CSF aspiration at this level. Now, so after ligamentum flavum, we have dura mater. In between ligamentum flavum and dura mater, in between ligamentum flavum and dura mater, flavum and dura, there is a small space that is called epidural above, before dura. That's why it's called epidural space. Epidural space. And in this space, we can have some fat. We have vertebral venous plexus and some fat around it. Okay, so we have epidural fat and vertebral venous plexus. Okay. So if there's a bleeding during CSF aspiration, it's from this vertebral venous plexus, internal vertebral venous plexus. Okay. So the first layer inside the canal is epidural fat. Okay. Here we have. So we have epidural fat and any bleeding that is from vertebral venous plexus. Then we have the dura, and then we have the arachnoid. And inside, so brain covering, dura mater, then arachnoid mater, and then pia mater. That is closely adherent to the brain. Closely adherent to the brain. So all the CSF and blood vessels are inside the arachnoid mater. Arachnoid mater. So after arachnoid, that is subarachnoid space. In this space, we get CSF. So these are the questions they ask you in your exam. If blood comes out, everything, these are the recalls. These are the recalls. That means these are the questions they frequently ask in the question in the main exam. That is your, if blood comes out, it's from vertebral venous plexus. When do you find resistance? Just ligament of flavum. The resistance is gone. You are at epidural space. From where do we take CSF? Subarachnoid space. First layer inside. All of these things are 100% important. All of these things are 100% important. And if we talk about a spinal cord, then okay, gray matter, white matter, all of these things are not important. But if we see the spinal cord, we can see that this will be the epidural fat. These YOLO things. These YOLO things will be your epidural fat. And here we will have vertebral venous plexus. Then we have intervertebral disc. Intervertebral disc. Remember, not everything is important. Everything I skip is unnecessary. And every important thing will be described because there are a lot of things. Do not waste time, not yours. Do not waste time. So, inside we have nucleus pulposus. Outside we have annulus fibrosus. Only remember that nucleus pulposus is a remnant of notochord. And if we get a prolapse or PLID, or prolapse, just simply prolapse, what will happen? This nucleus pulposus will come out. This nucleus pulposus will come out. Why? Why do we get prolapse? If annulus fibrosus is deficient, deficient. Guys, I don't teach you the words they used in book. I teach you the words they use in exam. So that's why our success rate is so high. Because this is the exact word. These are the exact words they use in the exam. Which part is deficient? Annulus fibrosus. So you get very familiar to the words they will use in the exam. And in every topic, in everything, we have done this. Now, then we need to know the apertures of diaphragm. Three apertures, three contents. This is very easy. T8, 10, and 12. See, T8. So first thing is vena cava. VENACAVA. 1, 2, 3, 4, 5, 6, 7, 8. So we have it at T8. That is inferior vena cava. Just remember vena cava. With vena cava, we get phrenic nerve. Okay. With vena cava, we get phrenic nerve, branches of terminal branches of right phrenic nerve. Okay. Then and lymphatics. You have to know all three. You have to know all three. Then at T10 we have esophagus. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. O. Okay. We forgot O. O. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So at T10, we get esophagus. And with esophagus, we get vagus. Okay. With esophagus, we get vagus. So remember, with esophagus, we'll get vagal trunks and esophageal branches of left gastric vessels. Remember, all three 100% important. Then at T12, abdominal aorta. If you know T8 and T10, you will always remember T12, abdominal aorta. But remember, with abdominal aorta, we get two other organs. Two, not organs, structures. Say structures. So, ATA. Aorta from ATA. From aorta, remember these three words ATA. Aorta, thoracic duct, azygos vein. Aorta, thoracic duct, azygos vein. Azygos vein. Aorta, thoracic duct, azygos vein. All of these three you must remember because they ask you all these. So see. So here we have vena cava. Okay. vena cava with right phrenic nerve. Then we have esophagus, vagal plexus, vagus, esophagus and vagus. And then we have a, this green one is T, then A, aorta, thoracic duct, azygos vein. Now, there is a very important thing you need to remember. That is, thoracic duct will go up, 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 and at, let's say this is T4, this is T5. T4 5 level, it will cross from right to left. Now, what's wrong with that? Esophagus is going up. If you have a carcinoma of esophagus, let's say at the middle portion, okay, let's say at the middle portion, and you, after or before resection or due to any time, or at lower part, you pull the esophagus up, what will happen? This is a very delicate structure. It will get compressed against the vertebra and it will get lacerated, and all the chyle inside it will leak. But we don't want that happen. So what do? We ligate it or divide it routinely. This is a routine procedure. We ligate it. Where? We ligate at the place it enters. At the place it enters. Now, so what are the questions you are going to get? Let's see. You will have a scenario, exactly this scenario, exactly these are the questions you will get if they ask you a question about it. Number one, they will ask you, there is a carcinoma at, let's say, upper third of esophagus. Upper third of esophagus. Now you are doing esophagotomy and you have to pull the esophagus up. Which structure routinely will require division or ligation? Thoracic duct. Number two, where will you ligate? At T12. Number three, where will you ligate? At its point of entry, at aortic opening. Aortic opening. So these are the only questions you will get from thoracic duct. Only these questions you will get from thoracic duct. Other than that, nothing is important. Nothing. Then give a reading, not important. Then diaphragm, artery supply, venous drainage, nerve supply, not important. You can give a reading. Okay, you can give a reading just for your, just for the calmness of your heart. Okay, other than that, there is no application of these things. But you need to know about this one. The diaphragm is supplied by phrenic nerve, centrally phrenic nerve, and peripherally intercostal and subcostal nerve. Now, will they ask you directly where? No. What will they ask? This is the apex of lung and this is the first rib. If we have a tumor at first rib, I have told you that I like in head neck classes, you will see that if we have a tumor at lung apex, medially we have phrenic nerve. Phrenic nerve. Phrenic nerve is very important. So we have anterior scalene. In front of it, we have subclavian vein. Behind it, we have subclavian artery. And on anterior scalene belly, we have phrenic nerve. Phrenic nerve is coming down and entering the thorax. While entering the thorax, medially, it has brachiocephalic vein. Now, it will enter the thorax and it will go and supply the central part of diaphragm. So, anytime your carbon dioxide level is high, carbon dioxide level is high, that means your respiration, anytime your respiration is stopped for few minutes or normal rhythm, your carbon dioxide accumulates inside your body. Your medulla will sense that carbon dioxide has increased. How? Through aortic body and carotid body. So aortic body and carotid body, from aortic body vagus, from carotid body GP, will tell you that these are oxygen sensor, oxygen is low, and carbon dioxide has no blood brain barrier. It will directly cross the blood brain barrier and medulla will know that carbon dioxide is increased. That's the primary drive of your respiratory center. I will tell you in respiration. So whenever carbon dioxide is high, primary drive, and in the meantime, we will have oxygen level 2 from GP and Vegas, not important right now. Your medulla will signal through C345 through phrenic nerve to diaphragm. And diaphragm was like this, and it will contract and it will become like this. So we get this extra space, that is vacuum, and air will enter. So if, let's say, signal is going like this, but here we have a tumor, that is superior sulcus tumor, that is medially pressing the phrenic nerve. So this signal is blocked. So we can have diaphragm paralysis. Diaphragm paralysis. So that's why this is very, very important. These are the questions you are going to get asked. That in case of a lung apex tumor, what can be the complication? They will ask you about the complication. And if you get question, if you get this question, do you need to know 20 complications? No. Only the one I tell you, that is diaphragm paralysis. Diaphragm paralysis. So you get a lot of complication, a lot of things, but you need to know the one I tell you to remember. Okay, then what happens? Then this is our diaphragm, and here we have spleen. Okay, so due to any reason, let's say Epstein-Barr virus has attacked our spleen. So our spleen gets bigger, 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 and it's pressing the surrounding structures, and it's causing some pain, dull pain. Now this pain is going to abdomen. This pain is going to abdomen. So it's over our diaphragm. Okay, it's over our diaphragm. So it's irritating the diaphragm and the peripheral part of diaphragm. So if you get a pain at your left upper quadrant of abdomen, that's radiating to abdomen. Okay. So the referred pain is taken by subcostal nerve, intercostal and subcostal nerve. So that's how they ask that which nerve supplies the periphery of the diaphragm. So this is the surgical anatomy you are going to deal with. You will get only these questions I mentioned specifically. If they ask about this question about peripheral supply of diaphragm, they will ask you this question. Then, if they ask about central portion, what will they ask? So, central portion is here, and we have heart here. And again, we have gallbladder here. Gallbladder here between central and peripheral, jai ho. Anyway, so central and peripheral. So, gallbladder inflamed due to some reason, and it's irritating diaphragm. It has a direct supply from right phrenic nerve. Okay. Other than that, phrenic nerve is supplying this area, central portion, and its dermatom is C345, and that's around your shoulder. That's around your shoulder. 3, 4, 5. That's around your shoulder. So this pain, pain, your right shoulder pain is referred by phrenic nerve. Phrenic nerve. If the person has cholecystectomy and the pain is going to right shoulder, so phrenic nerve is doing the referral. That's it. Okay. So these are the questions you're going to get. Then plane. All of the planes you must know, but you must know transpyloric plane. This is the most important. Others are less important. Still, you need to know all of the planes and all of the organs that you will find here. They will not ask you that which organ, which organ. No. They will tell you L1 at transpyloric plane. You have to know the serial. So in front of L1, we will have aorta, inferior vena cava. Okay. Then we will have pancreas. Then we will have pancreas. Which part? Neck of the pancreas. And they gave you a question that in case of a burst fracture of L1 vertebra, which structure will get injured. They did not mention aorta, they did not mention inferior vena cava, they mentioned neck of the pancreas. So they're just asking at transpyloric plane. So L1 is transpyloric plane. You need to know all the organs at this level and the serial of it. Okay, so they will ask you questions like this. So you must know all of these are 100% important. Okay, you can see it very clearly that here we have pylorus and hilum of the kidney. Hilum of the kidney, both kidney. But here we have liver. So this kidney is slightly down. Okay. So right kidney, upper part, upper pole of hilum, and left kidney, lower pole of hilum. That's it. That's it. And then we have neck of the pancreas. Then we all know that at L1 we get superior mesenteric artery and superior mesenteric vein. Okay. So you need to remember these things most importantly. Okay. Duodenal flexure. Then we have fundus of the gallbladder, origin of portal vein, then second part of duodenum, origin of superior mesenteric artery, ninth costal cartilage, hilum of the spleen, end of spinal cord. Do not forget the end of spinal cord. Then here we have previous question exams with explanation. After you study all this, solve this by yourself. Do not see the correct answer first. Then you read the explanation. So what do they ask? They will ask you, here we have rectus abdominis muscle, and they will ask you bullet injury slightly right to the rectus abdominis, or where we have rectus abdominis muscle, we have this kind of a line that is called linea semilunaris. So bullet injury at the edge of linea semilunaris will affect or injure gallbladder fundus. You can see it very clearly. That's why I gave you this thing. Okay. So this is very important. Layer not important right now. They will not ask you. Dermatome, just remember these dermatome. Nipple T4, umbilicus T10, and inguinal ligament L1. For appendicectomy or other inguinal ligament surgery, we need to block from T12. So these are the question they will ask you. Not important. Then here is your inguinal region, inguinal canal. First, you need to know the boundary. This one here, the one I have shown you in 3D. So that's what it is written here. That's it. Anterior wall, roof, floor, posterior wall. That's it. And content: ilioinguinal nerve, genitofemoral nerve, and of course spermatic cord and round ligament of uterus. They don't ask. So ilioinguinal nerve, the point you need to remember that it does not pass through deep inguinal ring. Number two, number one, it does not pass through deep inguinal ring. It sits on the spermatic cord. Then number two, see, ilioinguinal nerve will come out through lateral border of psoas major, and then it will go to your inguinal canal, go inside your inguinal canal. Now, when you give an incision for appendicectomy or hernia repair, it's very common to injure this nerve. Okay, so you will give an incision here at this area. So if you have injured here, what will be the signs? It supplies your anterior scrotal skin. So you will have no sensation at anterior scrotal skin, right? So what will happen? They will tell you that a person after having appendicectomy is complaining of numbness over anterior scrotal skin. What can be the reason? Ilioinguinal nerve injury. And if they ask you question, they will give you this question only. They will give you this question. Okay. So then they can tell you about hernioplasty operation too. After operation, If you don't have anterior scrotal sensation, it's always ilioinguinal nerve injury, and this is very important. Very important. And genital branch of genitofemoral nerve. Okay, supply. Do you need to know all the supplies? No. Just remember ilioinguinal nerve supplies. The thing I have told you. That's it. Then descent of the testis. All of the lines are collected from previous questions. That means recalls. So if you do my classes, you don't even have to study the recalls separately. So it depends on gabernaculum atrophy, not a correct statement according to books. Not a correct statement. I am telling you again, this is not a anatomy standard statement, but this is the statement they give in the exam. Okay, remember it. So undescended testis will be due to gabernaculum atrophy. I'm not writing a textbook. I'm writing a book so you can get your question correct in your exam. Okay. Then cryptorchidism and undescended testis. See, anytime if the testis is not in the scrotum, this is called cryptorchidism. Now, it can be ectopic or it can be undescended. So, what is an undescended and what is an ectopic? Undescended is it's in line of inguinal canal, but this is not, this has not descended. So, let's say a 6-month boy came to you and you don't find the scrotum, testis inside the scrotum. What will you do? If you don't find it, you immediately visualize under GA. Okay. And before or at first birthday, do orchidopexy. But these days we don't do orchidopexy. Why? Because orchidopexy is linked to seminoma. Seminoma. Okay. And that's why they give you this question. And they will ask you that a person came with a testicular mass. So first and most frequently asked question from here is number one. A person came to you with testicular mass, and then he gives a history of an operation at childhood. That's it. They will not mention anything else. They will just tell you that a testicular mass and an operation at childhood. That's it. So you be very sure that only operation they will mention in MRCS part A is orchidopexy. And that's the only one that's linked to testicular carcinoma, seminoma. For MRCS part A, you don't need to know anything else. Okay. And common age given is 42 because its common age is 40. Okay, they will give you this age. So this is about undescended testis. From undescended testis, they ask you this question and this question. Only these two. Only these two. Then cryptorchidism. Then your this one you can give a reading. Not important. They don't ask. Ectopic testis. They will ask you that which one is an ectopic site. Most of the time they give you this root of the penis in the femoral canal, in the pubopenile region, and during exam you are stressed, and that's why you might mistake it for inguinal canal. But remember, they mentioned femoral canal, not inguinal canal, so that will not be right answer. Contents of somatic cord, just know the names. Just know the names. Names, just know the names. They don't ask anything detailed. Layers of scrotum is 100% important, but not all the layers. You have to know that external spermatic fascia comes from external oblique aponeurosis. Premenstrual muscle and fascia comes from internal oblique muscle. 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 Point to be noted. Internal spermatic fascia comes from fascia transversalis. Then we have tunica vaginalis, visceral layer, parietal layer. Now, let me tell you a very interesting thing. Let's say you get a question that a 4-year-old boy, mother notices that morning, at the morning, when the child is playing at the evening, he got some swelling at his groin. But At the morning, there is no swelling. What does that mean? That means that person, that child has a patent processus vaginalis. Now, what is a patent processus vaginalis? Guys, see, when we are in our mother's belly, our testis is inside our belly. That is abdomen. Okay. When we are in our mother's abdomen, our testis is inside our abdomen. So, what will happen? We have gubernaculum right there attached to our scrotum. And it's getting atrophied, and it's coming down, coming down, coming down. So now it's in abdomen. Now, in case of abdomen, all abdominal organs, we get two layers. That is, one is peritoneum, right? One is parietal peritoneum, another is visceral peritoneum that's attached to the viscera that makes the viscera shiny and you cannot separate it from the viscera. So it's coming down, coming down, coming down. Gubernaculum is atrophying. So what will happen? So if this is our testis, this is our peritoneum, it's coming down, this is our scrotum. Its destination is here due to gubernaculum atrophy. It will come with a layer of peritoneum. Okay, it will come with a layer of peritoneum. See, this peritoneum will bulge out and it will come. So what will happen? It will come more. So this is the scrotum and it will come like this. Now, when it has crossed abdomen, we cannot say it peritoneum again. We call it tunica vaginalis. Now, as it was parietal peritoneum, this has become parietal layer of tunica vaginalis, and the visceral layer or visceral peritoneum has become visceral layer of tunica vaginalis. Now, this road or this part, this is a process. This is called processus vaginalis. Processus vaginalis. Now, this gets obliterated, but in case it does not, in case it does not, then we will call it that this processus vaginalis is patent. Now, what will be the problem? We have peritoneal fluid here. It will just enter this area because this is open and we will see a bulging. Okay, so that is called infantile hydrocele. Infantile hydrocele. Now, if it does not come as I told you, this water, if this water goes, this goes up to this area, that is totally down. If this water comes up to this area, okay, and it does not go back, then what will happen? That's not infantile hydrocele. That's full hydrocele or hydrocele. And they ask you that where is the fluid? Fluid is in between parietal layer of tunica vaginalis and visceral layer of tunica vaginalis. Simple. They will ask you about where is the fluid. Then nerve supply of the scrotum. Nerve supply of the scrotum. So posterior scrotal nerve, anterior scrotal nerve, genitofemoral nerve, and perineal branches of posterior cutaneous nerve of thigh. Okay, so posterior inferior surface, remember all of these names and where they supply. Anterior scrotal nerves, anterior side, genitofemoral nerve, anterior lateral side. Remember it. And these are the frequently asked questions, 100% important. As you are studying it for the first time, remember everything line to line. Triangle of Hasselbalch. The triangle I have shown you, that inferior epigastric artery, and laterally we have deep inguinal ring, and medially we have nothing. Now, if any hernia goes inside this ring, we call it indirect hernia, and any hernia that's medial to this inferior epigastric artery, that is called direct inguinal hernia. Now, this area that is frequently, this area that is frequently affected by this area. So this area we get direct inguinal hernia, and we call it a triangle. We are seeing it from inside, where medially we have rectus abdominis, inferiorly inguinal canal, laterally inferior epigastric vessels. How they ask you this question? Either plainly they ask the boundary, or they will tell you you are doing an inguinal hernia surgery, and medially you extend the incision. Medially extend the incision. Which structure will get injured? Rectus abdominis, because medially we have rectus abdominis. 100% important. Then we have, just give a reading. Other than that, nothing important, just the thing I told you. Peritoneal ligaments, give a reading. But most important is this one I have shown you in the 3D model. Ligament of Treats, give a reading. Epiploic foramen, 100% important. So anteriorly we have this hepatoduodenal ligament. The one I have showed you, that I told you that behind we have epiploic foramen. Okay. So anteriorly we have epiploic foramen. Anteriorly we have hepatoduodenal ligament, that is free edge of lesser omentum and containing portal vein, hepatic artery, and bile duct. Posteriorly inferior vena cava. Okay. And we know this is 100% important. Superiorly we have liver, we have seen it. And this is called Pringle's maneuver. Collection of pus. If this is our stomach and we get an anterior stomach perforation, what will happen? There will be leakage of fluid, and this will be collected at the most dependent part, that is hepatorenal pouch of Morrison. Hepatorenal pouch. If the person is supine or lying in bed, that means supine. So hepatorenal pouch of Morrison. If we have a posterior gastric perforation, first you will go to omental bursa, and then it will go to hepatorenal pouch of Morrison. Now let's say the person is sitting or standing. In case of that, the it will go to rectouterine pouch of Douglas or rectovesical pouch in pelvic cavity. That's it. Standing pelvic cavity, it just goes to the dependent part. These are just to see. These are just to see. Okay, give a reading. Tip of ninth costal cartilage, we get fundus of gallbladder. That's it. Then comes esophagus. Okay. Relations, musculature, not important. Esophagus, you will find it in thorax in details. Okay. From here, just know the origin. The rest give a reading. Others not important. The main thing about esophagus is uh, lymphatic drainage, artery supply, then its constrictions, and what are the questions come. Remember from thorax. Upper one third, middle one third, lower one third. Just know the name of the musculature. Then stomach. Give a reading about parts. Others not important at all. They don't ask anything. 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 Then we have blood supply. Artery supply. Very important. Just the way I told you in 3D. Just the way I told you in 3D. What you will do, you will open the 3D and open our book, and here you make the notes I have told you. So that's how you remember, and I make you remember things. You must do that. Venous drainage, give a reading, not so important, but lymphatic drainage is important, 100% important. Give a reading, not important, they don't ask anything. Duodenum, number one, that is just this line, 100% important. Others just give a reading, they don't ask anything, they don't ask anything from all these things. But a lot of people wants to read those things, that's why we gave it. But they don't ask this in the exam, they only ask this one. this information. Blood supply 100% important above major duodenal papilla, superior pancreaticoduodenal artery from gastroduodenal artery, and inferior pancreaticoduodenal artery from superior mesenteric artery. Remember this. And veins 100% important. Just remember this. Relations are the most important thing here. Relations are the most important thing here. You must know all these things 100%. Anteriorly, I have shown you that we have gallbladder, but we cannot show liver there. So remember, quadrate of lobe of liver, we have it here. Then we have gallbladder. Okay. Then we have first part of duodenum. Remember the serial. Then we have bile duct, hepatic artery, portal vein. Then we have epiploic foramen. Then we have inferior vena cava. So these are posterior serial relations and these are anterior serially relations. Above we have cystic duct. Okay. Inferiorly head and neck of pancreas. So all of these are important. So these two lines you must remember it. I have told you. Then second part of duodenum 100% important. 100% important. So anteriorly, we have gallbladder, right lobe of liver. Then we have this flexure that is called hepatic flexure. Then we have transverse mesocolon. Remember mesocolon, transverse mesocolon. Then we have some coils of small intestine. You must remember all of these. They ask you question from here. Posteriorly, we have kidney, hilum, and IVC. IVC. And of course, psoas major, right? Psoas major. So these are 100% important. Third part also 100% important. But no, I will say third part is 50% important. They never ask anything from third part, but they ask you this question. Structure related to both second and third part of duodenum. So these are less important. You can study if you want, but they don't ask any question from here. This one too, less important. I will say 50% as compared to other two. They never asked any question from here. Never. Jejunum and ileum, you can give a reading, but remember the statement I tell you. How do you differentiate in between jejunum and ileum when you are doing any surgery in the small intestine? Because it has longer vasa recta. Jejunum has longer vasa recta. And if you have a question, you will directly have this question with this being the right answer. Right answer. Then you have blood supply, give a reading, not important. They don't ask. They never ask. Large intestine also, they never ask anything. Just this line. 100% important. Just this line. Just know this line. Other than that, nothing is important. Artery supply. Just the way I told you that you need to know that appendicular artery is a branch from ileocholic artery. Okay, and it's an end artery. And what are the branches? Ileocholic artery, right cholic artery, middle cholic artery from superior mesenteric artery, and from inferior mesenteric artery, left cholic, and sigmoid artery, and superior rectal artery. These three. Okay. So the site of anastomosis between superior mesenteric artery and inferior mesenteric artery is this one between middle colic and left colic. Left colic. They are friends. Remember, 100% important with distribution. Very important. 100%. Lymph drainage, we have it later. This is 100% important, but if we have it later. Rectum and anal canal. Give a reading. They don't ask anything. They don't ask anything. See, they will ask you about DRE. Okay. What will they ask? They will tell you that you are doing a DRE. and posteriorly you are finding some hard structure. Anteriorly we have, okay, as if this is the first time, remember the relations. Remember the relations, they don't ask any question, but remember it, it will help you answer questions. Posteriorly tip of coccyx, anteriorly prostate, seminal vesicle, and in case of female, cervix. So if you find a hard mass of prostate, so in front, that's prostate. If you find something rough or tight behind, that's puborectalis. Puborectalis, posterior medially. Okay, that is a part of levator ani. Just remember puborectalis. We all know the blood supply of rectum, superior, middle, and inferior rectum, and veins. Same name, three veins, and lymph drainage. This is, I will say, 200% important. You will not have an MRCS diet without this question. Without this question, there is no diet of MRCS, no exam of MRCS. So always remember that here we have dentate line. Okay, above it and below it. Above it, the lymph drainage will go to internal iliac nodes, and below it will go to superficial inguinal nodes. And they will ask you that a person is having carcinoma of anal canal, where you will find lymph node enlarged, superficial inguinal nodes, superficial inguinal. Okay, then so anal carcinoma will go to superficial inguinal. Now, thing is, superficial inguinal lymph node has two groups. Two groups. One is vertical, one is horizontal. Now, remember this arrow. Here are our legs and here is our perineum. Okay. Remember lower part of anal canal. Okay. Labia. These drains into horizontal group of these. See this arrow, horizontal group. Horizontal group of superficial inguinal lymph nodes. Okay. And lower limb drains into vertical group. Just remember these two informations. Okay. Then we have nerve supply. Remember lumbar splanchnic nerve and hypogastric plexus, they will give you sympathetic supply. Sympathetic supply. Contract the sphincter, relax the smooth muscle, inhibit defecation. Guys, sympathetic and parasympathetic, I have explained in physiology, shock. After that, you will have clear understanding of this one. Okay. So sympathetic is fight or flight response. Let's say Mike Tyson is in front of you and he wants to fight you or give you a punch. What will happen? If you cannot fight Mike Tyson, right? You will run away. You will run away. You will take a flight. So what will happen? Is this the time to defecate? No, no, you cannot defecate now. Is this the time to urinate? No, you cannot. Like some people say that urinating out of fear. No, that's a different thing. So This is a flight response. You have to run. You cannot defecate or urinate right now. So what will happen? So if this is a reservoir, either it's rectum or bladder, what will happen? The gate will be closed tightly. Gate will be closed tightly. So because this is not the time. This is not the time. Gate is closed. And the reservoir or the bag will relax. So you can wait some time if you need to go. Because if this is contracted and the gates are closed to, it will burst, right? That will be +1. First problem was Mike Tyson was throwing you a punch. Second problem is now your rectum is bursting. So your body will not add another problem. So what will happen? The muscles here will be relaxed. So you can wait some time if you need to urinate or defecate. So in case of rectum, in case of rectal, smooth muscle will relax and external sphincter will be tight. Okay, tightly closed. In case of bladder, in case of bladder, detrusor, detrusor will relax and external sphincter will be tight. Simple. So this is the sympathetic effect in your bladder and your rectum. Then here we have it. You need to know. They ask you from where you get sympathetic supply, hypogastric plexus. And what kind of fiber you have here? Preganglionic fibers. Preganglionic fibers. Then you have pelvic splanchnic nerve. Then we have somatic. That means touch, pain, temperature sensation. These are from pudendal nerves, inferior rectal nerve. Okay. Below the dentate line, voluntary control of rectum through external anal sphincter. Okay. So lymphatic drainage of rectum and anal canal, very important, 100% important. So upper rectum, inferior mesenteric nodes and pre-aortic nodes. Okay, very important. Middle and lower rectum, all of this, all of this, 100% important. Then you have anal canal, 100% important. Remember superficial inguinal mainly, 100% important, 100%. So these are the shortcut. You must remember all of it. They ask you questions. They ask you questions. Okay. These are, you can give a reading, not important. These are the questions. You see the explanations. Then we have liver. All of these things you can give a reading. They don't ask any question. Remember fundus of gallbladder at tip of ninth and this question. Bullet passing through lateral border of rectus sheath, injured structure, gallbladder. And you just need to know the segments and blood supply. 100%. Others not important. They don't ask the boundaries of quadrate lobe, chordate lobe. They don't ask. But if you want, you can give a reading. Not so important. You don't have to waste much time on these things. But these are most important things. Ligaments, just know the names. They don't ask anything. Just this one. Ligamentum teres hepatis or round ligament of uterus. So from umbilicus, we'll get three lines. One is in the midline. In the midline, this is ligamentum, ligamentum teres hepatis. Okay, ligamentum teres hepatis. So this will go upwards, upwards, and this was umbilical vein at the fetal circulation. This was umbilical vein. Okay. So from this one, this was umbilical vein. It used to carry oxygenated O2 rich blood to fetus. To fetus. Now, going down from umbilicus, you will get three ligaments. One is median umbilical ligament with an N, and two lateral ones are medial with L umbilical ligaments. So this median umbilical ligament is was connected to bladder, and these two was umbilical artery, which used to take deoxygenated blood, deoxygenated blood from fetus to placenta, from fetus to placenta. Okay, and median umbilical ligament is a remnant of urachus, urachus, which used to drain urine in the fetal life. So you remember all of these things and watch our fetal circulation video. Beautifully explained everything in short time, and you will be very clear about all these things. Bare area, give a reading, not important. They don't ask anything. Then gallbladder, everything about gallbladder is important. This one. So medially we have common hepatic duct. Where is the good picture? I don't see any. Okay. So inferiorly we have cystic duct. Superiorly we have inferior surface of the liver contains cystic artery from right hepatic artery. Know the branches. They give you two questions. Which one is the content, and which one is gives the branch? Which one gives the content of cystohepatic triangle of Calots? Right hepatic artery. Very important. Nerve supply, right phrenic nerve. Simple. 100% important. Very, very important. They ask you this in the question. Then spleen. They don't ask anything from spleen except this injury. Except this injury. Okay. Others give a reading. So here we have splenorenal or lenorenal ligament, and you can see that inside this ligament we have pancreatic tail and splenic arteries. Now, if you do a splenectomy, you have to ligate splenic artery, and that in turn can injure pancreatic tail. 100% important. This is the thing they ask very frequently. Okay, okay, pancreas. Then from pancreas, just remember that you can forget. They one time they gave a question that which one is not a part of gallbladder. They added neck with it. But remember, neck we have it in pancreas, not in gallbladder. Okay. So from this, you need to know the secretions, exocrine, endocrine. These are every line I tell you is a question from exam. So these are the questions you will have in your exam. Others give a reading. They don't ask anything. Only remember these things 100% important. They don't ask anything from here. Give a reading if you want. Otherwise, not important at all. Remember annular pancreas, 100% important. Though they just ask this thing, the anatomy. Others, we have a lot of time. We have 5 months. So you remember it. You study it. You remember it. Others give a reading. Not important. They don't ask the management. You can skip it, but you can give a reading if you have time. The kidneys, they ask, they don't ask anything from here. Give a reading. They don't ask anything. Not a single thing they ask from here. They don't ask. Just remember this one. We all know hilum contains vein, artery, pelvis. They ask you this thing, the relation of kidney. This is 100% important. They ask more about posterior relation. Remember, three muscles are behind. Okay. Immediately posterior, we get psoas major. Psoas major, we get Then we get quadratus lumborum and transversus abdominis. Okay, let me show you if we have a picture from behind. No, we don't. Okay, I'll show you it later on. Okay. So this is 100% important. Mostly they ask about posterior relation and anterior also important 100%. Remember all of it. And see from the 3D where I have shown you kidney, ureter. Guys, ureter is important. This one is not so important, but remember about the parts and constrictions. Why constrictions are important? If you have a stone, where will the stone lodge? At the constrictions, because these are the narrow areas. So there will be the stone, and it's along the lumbar vertebra transverse processes. Transverse processes. Okay. So at pelvic brim, at ureterovesical joint, at ischial spine, at pelviureteric junction. Tip of transverse process of L2. So you need to know the constrictions and artery supply. All of the artery supply you must remember. You must remember because they give you a question that which artery does not supply ureter. So that's why you need to know all of the arteries that supply ureter. Suprarenal glands. Remember, we make this mistake. It's covered by fascia of Gerota. And remember, GFR. These are physiology questions. They don't ask anything from here. Zona glomerulosa, zona fasciculata, zona reticularis. Not important. Give a reading because you already know these are physiology questions. They ask you from there. Other than that, here they don't ask anything. Don't ask anything. Okay. Okay. See. They will ask you this question. That's the relation of suprarenal gland. Suprarenal gland. They will ask you this thing. So lesser sac, stomach, crus of the diaphragm, then medially crus of the diaphragm, inferiorly pancreas and splenic vessels. So remember the inferior relation. Most of the time they ask about the inferior relation. So remember the questions. See the question. Read the questions. This is the question pattern. Previous question from here. And here we have previous questions. You see and you read the explanations. Read the explanation. Do not skip a single question. Do not skip a single question. Then abdominal aorta. See guys, here we have the branches. So anterior midline, celiac, superior mesenteric, inferior mesenteric, vertebral levels are 100% important for all of it. Celiac T12, superior mesenteric L1, inferior mesenteric L3. Then lateral or paired visceral at L1. Remember, sometimes they say L2, but it's guys see here we have L1, but remember uh, renal. This is the so they say that gonadal is L2, but it's just at this level L1 lower border or L2. So remember L1 lower border or L2. So it can be all at L2 or at L1. Okay. So at one place. So L1 or slightly lower than superior mesenteric. So suprarenal, renal, gonadal. Okay. Suprarenal, renal, gonadal. Then posterior lateral, subcostal, inferior phrenic, lumbar. Remember this thing, lumbar. Any back bleeding, any difficult back bleeding during kidney operation or any abdominal operation is from lumbar arteries. Inferior vena cava formation and vertebral levels are 100% important. Very, very important. So left common iliac vein is compressed. The one I have shown you that left common iliac vein is compressed by right iliac artery and my whole lower limb becomes edematic. edematic. So what happens? We get lower limb edema. We get lower limb edema, that is called May Thurner syndrome. They ask you these questions. This is very, very important. Here we have all the artery supply, venous drainage, lymph node drainage, and nerve supply at one place. At one place. This is nothing. After you study all of these things, this chart is for your recap. This chart is for your recap. This chart is for your recap. Okay. Now, then we have pelvis perineum. Pelvis perineum is short. So, first thing from pelvis perineum you need to know is the lumbar plexus. Guys, see, lumbar plexus is very easy. Just the amount I tell you, you remember that one. Remember L1, L2, L3, L4. That's it. So, L1 is Roman I. Okay. So remember ilio. So we will get two branches from L1. Ilio inguinal, ilio hypogastric. Then we have L2. Okay. And we get the branches from L1 and 2. That is 12. 12 is the age we get secondary sexual characteristics or our genital organs. Our genital organs fully mature. So from L1 to or 12, we get genitofemoral that has two branches, genital femoral. Okay. Then we have L3. Remember, L2, 3, 4 gives two nerves. Remember, L2, 3, 4 has two divisions, anterior, posterior. So L2, 3, 4, anterior obturator. L2, 3, 4. So anterior obturator, posterior femoral. That's it. That's the thing you need to know from lumbar plexus. So these are the nerves of lumbar plexus. What do you need to know? The supply. Only the sensory ones, genitofemoral. But remember about genitofemoral that genitofemoral innervates the cremasteric muscle. L2, 3, 100% important. That's a separate thing about lateral cutaneous nerve of thigh. Now, then obturator, medial thigh. Okay, and 100% important, 100% important actions. Then we have cremasteric reflex. Here we have it detailed, but you don't need all the details. You give a reading and just remember the afferent limb and efferent limb. The afferent limb is ilioinguinal nerve. The efferent limb is genital branch of genitofemoral nerve. That's it. Others you can just give a reading. Give a reading. Now, clinical importance is your absence of cremasteric reflex is a key sign of testicular torsion. And anytime they give you a question that severe pain in testis, severe pain in testis, they will give you one or two clue. Number one, first clue, one testis is higher, one testis is higher, and cremasteric reflex absent. Cremasteric reflex absent. So one testis is higher and cremasteric reflex is absent. Anytime they tell you these two things, this is testicular torsion. Testicular torsion. So that's why it's important. Give a reading to others. Okay. So guys, it's almost 1 a.m. at night. So I will record the rest and upload it tomorrow. So I'm finishing the class now. The rest which are left from pelvis, I will record it by daytime tomorrow and upload it. Thank you guys. Have a good night.